This 3D simulation shows a beating heart inside a translucent thorax. Watch what happens when the right ventricle suddenly collapses under invisible external pressure. The entire pumping cycle stops. Securing a 270 plus on your board exams means mastering the mechanics of this exact moment, obstructive shock. The lethality of major thoracic trauma almost always hinges on a single mechanical failure. Death occurs through the catastrophic restriction of right ventricular preload. Blood cannot enter the heart, so blood cannot leave the heart. From a macro hemodynamic perspective, these patients look identical. They present with severe hypotension and compensatory tachycardia. But the exact anatomical location of the constraint, whether it is pleural, pericardial, or parenchymal, dictates entirely opposite split-second interventions. We will deconstruct 3 specific etiologies that test this mechanism. 1. Tension pneumothorax, 2. Cardiac tamponade, and 3. Flail chest. Applying the standard airway-first trauma algorithm to these patients triggers the iatrogenic positive pressure trap. If misapplied, securing the airway will actively kill the patient. High-level clinical performance requires you to look past the bleeding and visual distractors in the trauma bay and focus purely on the underlying mechanical derangement of the right heart. Let's test this theory against the strict physiological parameters of our first clinical simulation. Recognizing the precise location of right heart constraint is the only reliable way to prevent rapid, pulseless electrical activity arrest. This cross-section shows the anatomical mechanism of a tension pneumothorax. A pleural tear acts as a one-way flap. Air gets sucked into the pleural space during inspiration, but the tissue flap seals shut on expiration, trapping the air inside the chest cavity. With every breath, that trapped air mass grows. It rapidly compresses the ipsilateral lung until it completely collapses, and then begins forcing the central mediastinal structures into the opposite hemithorax. Here is the hemodynamic collapse. That contralateral mediastinal shift mechanically pinches the superior and inferior vena cava. Right ventricular blood volume drops to 0. A simple pneumothorax and a tension pneumothorax share similar respiratory signs. Both present with unilaterally decreased breath sounds and hyperresonance to percussion. The defining variance is the cardiovascular collapse. A tension pneumothorax uniquely presents with severe obstructive shock parameters, hypotension and tachycardia, paired with jugular venous distension, as blood backs up above the pinched cava. This presentation creates the ultimate lethal contraindication. You must never perform endotracheal intubation before decompressing the thorax. Forcing positive pressure into an already overpressurized thorax instantly exacerbates the vena cava compression. You will shut off whatever minimal venous return remained, triggering immediate cardiac arrest. The intervention sequence is absolute: immediate needle thoracostomy to release the pressure, followed by a definitive tube thoracostomy. This clinical vignette from the NBME shows exactly how this is tested. We have a 19-year-old motor vehicle collision victim in severe respiratory distress, showing profound hypoxia, hypotension at 110/70, and right-sided supraclavicular distension. The choices force a decision between airway management, diagnostic imaging, and mechanical decompression. The correct answer is pneumothorax, managed by immediate tube thoracostomy. The explanation text confirms that evacuating the accumulated air is the only way to eliminate tension on the great vessels and permit lung expansion. In the presence of unilateral absent breath sounds and obstructive shock, touching the airway before decompressing the chest is a fatal error. We transition now to cardiac tamponade. This CT scan shows a massive fluid collection entirely encircling the heart. The constraint here originates from a physical barrier within the mediastinum, rather than pressure pushing against it. The physics are straightforward. Rapid accumulation of fluid inside the inelastic pericardial sac causes intrapericardial pressure to perfectly equal right ventricular diastolic pressure. This equalization of pressure physically arrests right ventricular filling. The chamber cannot expand, so stroke volume plummets. In penetrating trauma, this manifests as Beck's triad: hypotension, jugular venous distension, and muffled heart sounds. High-level board questions will test the complex hemodynamic signature of tamponade, pulsus paradoxicus. In a normal heart, taking a deep breath draws venous blood into the right ventricle, expanding the outer wall harmlessly outward. Now introduce the tamponade. The outer pericardium is rigid with fluid. When the right ventricle fills during inspiration, it has nowhere to expand but inward. It forcefully bows the interventricular septum to the left, shrinking the left ventricle's available volume. This septal bowing causes a sudden drop in left ventricular stroke volume. Clinically, this registers as a drop in systolic blood pressure of more than 10 millimeters of mercury during inspiration. Contrast this immediately with tension pneumothorax. Tamponade features identical JVD and shock, but the patient will have bilateral equal breath sounds and a midline trachea. Definitive treatment requires a needle pericardiocentesis, but the immediate resuscitative bridge is the administration of an IV fluid bolus. You must artificially elevate right-sided venous pressures to physically force blood past the pericardial constraint. Consider a vignette featuring a patient with a stab wound to the chest. They are in profound shock, but their lungs auscultate perfectly clear bilaterally. The options will tempt you with immediate intubation, chest tubes, or imaging. Your task is to select the temporizing measure while awaiting the surgeon. The correct answer targets the physiology. As this explanation text notes, bedside ultrasonography confirms the right atrial and ventricular collapse. Therefore, the immediate next step is rapid fluid resuscitation with crystalloids to increase preload before needle drainage. When the lungs are clear but the right heart is failing, hydrostatic pressure is the only way to buy time. We shift from pure hemodynamics to structural failure with flail chest, defined anatomically as fractures of 3 or more contiguous ribs in at least 2 separate places. This model displays the visual hallmark, paradoxical chest wall mechanics. The broken segment of ribs moves in complete opposition to the rest of the rib cage. The mechanics rely on the generation of normal, negative intrathoracic pressure. As the diaphragm drops, that vacuum pulls the free-floating bone segment inward during inspiration. This striking physical paradox draws the eye, but it is actually a clinical distractor. The mechanical bone movement is not what kills the patient. The true hypoxic driver is the underlying pulmonary contusion. The impact that broke the ribs caused severe alveolar hemorrhage and edema in the lung tissue directly beneath the fracture, blocking oxygen exchange. Management scales with severity. Mild cases demand aggressive pain control, often via epidural, to prevent splinting and hypoventilation. Severe cases, however, mandate a complete reversal of our previous rules. Severe hypoxia mandates intubation and positive pressure ventilation. Here, the positive pressure acts as an internal pneumatic splint. It forces the contused alveoli open for gas exchange and pushes the flail segment outward, synchronizing it with the rest of the chest wall. A final vignette demonstrates this concept. A 45-year-old female presents with paradoxical chest wall movement, severe hypoxia, and patchy alveolar infiltrates on X-ray. The distractors will offer surgical fixation or binding the chest. You must bypass the mechanical paradox entirely. In flail chest, you treat the parenchymal failure, not the bones. Positive pressure regains control of the contused lung. Surviving thoracic trauma requires instantly identifying the specific mechanical constraint causing the right ventricular failure. You separate tension pneumothorax from cardiac tamponade at the bedside by evaluating breath sounds and tracheal position. Never initiate positive pressure ventilation in an undiagnosed hypotensive thoracic trauma patient. If the cava is pinched, the ventilator will cause cardiac arrest. In tamponade, use aggressive IV fluid loading to increase right-sided pressures against the pericardial fluid while preparing the needle. In flail chest, recognize that the underlying alveolar contusion causes the hypoxia and leverage positive pressure ventilation as your internal splint. Trust the underlying physiology. Let the mechanical physics of the right heart guide your hands in the trauma bay and your answers on the boards. Top-tier clinical performance relies on understanding the physical mechanics of death precisely enough to reverse them.